Good morning, everyone.
Morning.
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 We are following up our last fortnight's renal physiology and anatomy tutorial with acute kidney injury, which I think is a really nice sort of segue because we can really talk about the anatomy with how acute kidney injury manifests while it's fresh in our mind, and review the physiology of what happens when we get tubular dysfunction versus glomerular dysfunction versus vascular changes or post renal obstructions and things. So the first thing I wanted to cover is, what is acute kidney injury? How would you define it?
Sudden onset or recent onset.
Yep.
And else what you call it, acute kidney injury. Yeah, probably by loss of function, I guess.
Good. Exactly. What is the function of the kidneys? Or one of, there's several, but.
Yeah, well, one of the ones we can detect are filtering of waste products.
Exactly, yeah. So the markers that we use to measure renal function are the excretion of nitrogenous waste. So creatinine, urea, essentially. So as far as how we define acute kidney injury, it's there's a pretty good criteria for how we actually sort of diagnose it, and it's surprisingly subtle. So one animal, when they're sort of normally hydrated, so if you sort of test an animal's creatinine level from day to day, it'll be actually really consistent. So there's very little variation, obviously variation between animals, but if you've got a baseline on one animal when they're normally hydrated, you can expect their creatinine to be the same the next day. So acute kidney injury is defined as an increase in creatinine of 25 millimoles per litre, which is not much, is it? If an animal sits at 80 and it goes to 105, we often don't interpret that as a change because it's still in the normal range, right? But that animal has undergone some renal injury. And then one of the other criteria is an increase in creatinine of greater than 50% of baseline. And then the other one is urine output falling below 0.5 mils per kilo per hour for greater than 6 hours duration.
Right. So do you have to have all three?
No, just one. Just one.
Just one.
Yeah. So if you've got, for example, if you become acutely auric, will your creatinine go up?
Yes, I think so.
Eventually, but you're retaining fluid at the same rate as you're retaining creatinine if you're acutely auric. And when you're measuring in a per litre basis, creatinine is actually going to be stable. So eventually it'll go up because you'll lose your fluid in other ways without being able to lose your creatinine. But the reason why they put that urine output one in there as one of the options is if an animal's like, say, it infarcts both kidneys at the same time, and there's just zero blood flow to the kidneys, your creatinine and fluid are going to go up at the same rate. And therefore your creatinine per litre is going to be the same. That's so rare. Just, it's not going to happen, hopefully. So one of those three criteria would be enough to diagnose acute kidney injury. I want to just harp on a little bit about that creatinine point and the fact that just an increase in 25 millimoles per litre is significant. And I'm just going to draw you a picture if I can operate the whiteboard. So at high, I'm going to draw a picture first. And I'm going to do it freehand, and it's going to be really messy. Oh.
Haven't got anything yet.
All right, so on this axis, we have creatinine. On this axis, we have GFR. So we're going low to high, right? So if we've got a very low GFR, where's our creatinine?
It's low as well.
Low GFR. So GFR is crap.
Oh, sorry. High.
High.
Not filtering. Yeah.
Good. Okay. So we've got kidneys aren't functioning properly. We've got very low GFR. We've got not much going on in the kidneys. Our creatinine is going to be very, very high. So the relationship between GFR and creatinine is hyperbolic. Is that the word?
Mm-hmm.
Yes. Good. Thanks. So as our GFR I should start at this end. So if we've got good GFR, what's our creatinine doing?
Low.
Low, exactly. So creatinine is going to be sitting around 80, and we've got excellent GFR, and then we're going to gradually have some kidney injury happening, and we're going to get a very slow rise in creatinine in that hyperbolic shape until we get below a certain threshold of GFR, and then our creatinine is going to go up quite exponentially. So if we're talking about early kidney injury, when you're starting with a really good GFR, and then all of a sudden our GFR drops by like 50%, we've actually got a very small increase in creatinine with a really significant reduction in GFR. Does that make sense to everyone?
It does.
Yeah. So that's why the creatinine is so significant. So how often do we see variation in our creatinine levels within a patient in hospital?
Not very often.
Not very often. Just going to close that whiteboard. Does anyone want that up for any reason?
No.
No, I want to see where your face is. Okay. So when do we do bloods most of the time?
I mean, the most common is anesthetic. Like people do it for anesthetic, sort of pre-anesthetic, and then sick animals.
Yeah. So sick animals for sure, pre-GA bloods, and just sort of wellness checks, medication monitoring and stuff like that, I reckon. Or usually patients that are recovering from illness. If you had done like a wellness check on a dog and they had a creatinine of 80, and then you did a pre-GA blood test and they'd been fasted overnight with water restricted and the creatinine had gone up by 40, how would you interpret that?
I would flag it. Sorry.
You can't really compare it.
They're dehydrated, right? So now let's segue from that conversation with that in mind to what are the causes of acute kidney injury? If we had to divide them up into sort of categories, and I sort of mentioned it a little bit before you were here, Josh, that means you have to answer.
I think, isn't it like it's kind of the same as like pre-renal, renal, post-renal. So
Exactly.
Like pre-renal, intrinsic, post-renal, I think it is.
Yeah. And the reason I want to flag that is because we tend to think of that as, is this azotemia pre-renal, renal, or post-renal? And we tend to go, oh, it's pre-renal. Great, don't worry about it. Because they've got a high USG, they've got good renal function. But actually, that meets the criteria for acute kidney injury. The acute kidney injury can be pre-renal. And if we don't then protect the kidneys, it's going to turn into renal. So that's a big pre-GA. If they're dehydrated enough to have that much of a jump in their creatinine, they need to be on fluid before they're going under GA, or need to have that as a consideration in terms of blood pressure management and things throughout the GA.
Can you explain that again? So the kidneys there's reduced glomerular flow.
Yeah.
You're saying that is an indicator of acute kidney injury, or just if you then persist with anesthesia?
So that meets the criteria of acute kidney injury.
I thought the criteria was if you were normally hydrated.
No.
Okay.
No, because
Right.
so that's if you're monitoring renal disease or renal injury, they need to be the same level of hydration each time you measure them.
Okay. Okay.
But when you're detecting an injury to the kidneys, they pre-renal counts is what I'm trying to say.
Gotcha. Okay. So, all right. Okay. So 25 millimole change in creatinine, irrespective of hydration status.
Yes.
Oh, okay.
Yeah, exactly.
And it might be reversible. Presumably, it's reversible.
Yeah.
Right.
Yeah.
Okay.
The trouble is for that, you need a baseline.
Yeah.
And the other criteria was 50%, an increase in creatinine of 50% above the baseline. So if your baseline is 50 in a dog, it's really easy to get to 75. But if your baseline was 120, then all of a sudden it's really clear that there's a difference there, but it's the same sort of same shift between GFR. So let's talk about pre-renal causes of renal injury. Dehydration, we've talked about. What else?
Hypotension.
Good. Yeah.
Bulimia.
Yep. Excellent. I'm not sure. So when in the textbook, non-steroidals and ACE inhibitors are listed as pre-renal causes of azotemia or of acute renal injury. And I guess it's pre-nephron, but it is in the glomerulus. So for me, that means renal, but technically it's listed in pre-renal.
But I don't know if furosemide might be pre-renal as well. Like, you know, those like heart disease dogs and cats that we smashed with furosemide.
That works for the lip of Henley though.
Yeah. So would that be renal or pre-renal?
Good conversation. I like this.
I was wondering before, and I was like,
yeah. So furosemide prevents retention of fluid in the loop of Henle, but the mechanism of creatinine elevation or azotemia secondary to furosemide is decreased renal perfusion from dehydration. So it is pre-renal, but you've actually stopped the kidney's coping mechanism, essentially, so they can't retain fluid. Make sense?
Yeah, it does.
So yes, I would put furosemide use and decreased cardiac output, both heart disease things, into the pre-renal causes.
And non-steroidals.
And non-steroidals and ACE inhibitors. So let's talk about the mechanisms of, should we do that now? Well, how does non-steroidal cause renal injury?
It constricts the afferent arterioles in the glomerulus. If you are, it prevents the prostaglandin
Yes.
dilating the afferent arteriole.
Yes, yeah, exactly. So the net effect is that you get constriction of the afferent arteriole. And we remember from our diagram last week, the blood coming into the glomerulus from the afferent arteriole, the blood going out of the glomerulus in the efferent arteriole becomes the blood supply for that entire nephron. So if we've got decreased blood supply coming into the glomerulus, you get decreased GFR, there's less filtration, but we've also got decreased blood supply to the rest of the nephron, and we get nephron loss because of hypoperfusion. So Bron was exactly right. Is everybody comfortable with that? How non-steroidals will cause a renal injury? What about ACE inhibitors?
That's the efferent. Dilates the efferent arteriole.
Yeah. What's that going to do to?
It decreases, I think, like pressure in the glomerulus, so you get less filtration.
Good, excellent. Does that make sense to everybody?
I missed the name of the drug. Sorry, ACE inhibitor. Sorry, ACE. Oh, ACE inhibitors, right?
Yeah. So ACE inhibitors will dilate the efferent arteriole, which decreases glomerular pressure. And that means that there's less pressure and therefore less filtrate produced. So you end up with a lower GFR. Okay, so they're pretty much the pre-renal causes according to, when I say the textbook, my notes are a combination of Edinger, which is written by Kathy Langston, and she's the renal guru for kidney injuries, and CVT 15, which has quite a good chapter on AKI, if anybody's interested. See if there was another resource. But I'm more than happy for people to bring new resources and textbooks and things like that, and we can look at new information as it comes out. But I am now stuck in my ways, and you'll have to bring it yourself.
Anna, would hypertension be one as well? Would that, like, how does that fall into it?
That's a really good question, actually. So I've got pre-renal as perfusion, and then this is why I can't really put the non-steroidals and ACE inhibitors in that same category, but that's
overlap, I
where
guess.
they are. Yeah, but I've got hypertension and DIC, stenosis vasculitis and stuff in renal, in intrinsic. So that's just sort of the way it's classified, but I would have put them in together in terms of the effect that they have on GFR and filtration. Okay, so let's move on from pre-renal to intrinsic, vascular being one of them, one of the categories. What other causes of an intrinsic acute renal failure might we have?
Toxicity would be
good. Toxicity of, let's divide it into parts of the kidneys.
Oh, okay.
The vascular, this one.
I don't know the answer to that, but I know that, like, things like ethylene glycol affect tubules, I think. And aminoglycoside, like gentamicin. I don't know where that damages the kidney though, but
me neither. Sorry. Yeah, I can't remember.
And then like toxicity in cats.
Yeah. So I was thinking, rather than individual toxins, like regions of the kidney that might be injured and different mechanisms that might injure them. So, and we're sort of thinking about what disease processes we might manage in a hospital that we need to be on the lookout for AKI development. And toxicity is definitely one, because hospital acquired acute kidney injury is more common than community acquired.
Right.
So we've got vascular injury, and then Josh has mentioned a couple of tubular injuries.
Pigment, like bilirubin, myoglobin, due to clogging up some part of the nephron.
Yeah, absolutely. So again, tubular.
Right. Yeah.
But pyelonephritis, is that an infection of the kidney? Yeah.
Yeah. So pyelonephritis can be of two like different.
Ascending and hematogenous.
Good. Excellent. And which parts of the nephron would be affected with the different?
Yeah, I guess with ascending, it'd be going up into the pelvis, and then I'm not sure if it affects the tubule through the collecting duct.
Exactly right. Yep. Exactly right. Yep.
I guess hematogenous could be anywhere in like cortex, probably.
Yep. So anywhere.
Like glomerulus.
Where does the good?
Probably the most likely, because bacteria would get stuck there.
Good, exactly. So glomerular injury versus nephron injury will present quite differently. Well, not really, but we'll pretend they're really clean cut. So what might the difference be in your urinalysis, for example, with an acute glomerular injury versus an acute nephron injury?
The glomerular injury have more protein loss, because that's one of the markers for glomerular disease.
Yeah, so higher grade of proteinuria for sure with glomerular disease, if we've got glomerular damage. And what might we see with a tubular injury, a proximal convoluted tubular injury?
Like casts.
Casts, good. Yep.
Glucose.
That's, I reckon, the big one that really tells us that this is a tubular injury rather than a glomerular injury, because the glucose is all filtered, gets into the nephron, gets into the tubule, and that should all be resolved. And if you've got dysfunction of that proximal tubule, you'll get glucosuria. Okay, so we've got the vascular space, we've got the glomerulus, we've got the tubule as kind of regions that can be intrinsic causes of acute kidney injury. And then the other one is the interstitial space. And the reason I want that sort of classification in your head, that vessel, the interstitium, the glomerulus and the tubule, is because as we talk about the pathophysiology and how acute kidney injury can turn bad and how we're going to manage it, I want you to really envisage that you've got these really floppy tubules sitting in amongst an interstitium, which is a fluid-filled space, and a blood vessel, and any change in volume in any of those compartments will impact those nephrons. So if you've got this floppy tube running through a compartment that gets edematous or swollen or infiltrates of inflammatory cells, it's going to get squashed, and we're going to decrease GFR, same, and blood flow for that matter. So just want you to sort of keep that in mind, all of those 4 compartments, and how one injury in one compartment can lead to injuries in other compartments. So is everyone familiar with the iris?
Did you give us any examples of intrinsic causes? Like hypertension or edema from something, or? Sorry, I didn't finish that sort of section. You're right. So we're talking about the different forms of AKI, pre-renal being one, intrinsic being another one. I shouldn't say causes, I should say categories of AKI. So we're talking pre-renal, renal being, I've used the word intrinsic just to confuse everybody, but actually within the kidney rather than a pre-renal or post-renal cause. And we didn't actually talk about post-renal. So what post-renal causes of acute kidney injury do we see most commonly?
Urethral obstruction.
Good. Urethral and?
Urethral.
Urethral, yeah. So we really, with urethral obstruction, they're like, it's so acute, and they're like, the bladder ruptures, like it's so sort of catastrophic that the kidney injury is, I guess, less of a concern, whereas a urethral obstruction is more often partial, more often chronic, more often undetected clinically because they often don't develop an azotemia. But certainly that's, I would say, one of the leading causes of post-renal injury that we see.
Wouldn't partial urethral obstruction actually be chronic, because it's not going, like acute, by definition, chronic is more than 3 weeks. So like it would be more likely chronic just because of the time sort of.
It depends a little bit. So we see these patients so often where they've had a stone obstruct one kidney or one ureter, and they've lost that kidney. Essentially, that kidney is no longer functional. So we can see patients with then an obstructed other kidney. They're still producing urine, so it can't be a complete obstruction. But they present quite acutely because they've got so little renal function reserve. So acute, you're right, the 3 weeks is the cutoff where we kind of say it's acute versus chronic. In fact, I think chronic is actually 3 months when we talk about renal disease.
Yeah, 3 months.
Yeah. So it could turn chronic for sure, but it starts in the sort of the process of the disease. We often don't diagnose it, but it starts obviously with an acute injury, and then it progresses to chronic if it stays obstructed.
Yep.
How long does a ureter have to be completely obstructed before you get no GFR return when you unobstruct it?
3 weeks.
Pretty close, actually. It's actually 6 weeks. It's way longer. Like you sort of see a kidney that's obstructed and go, oh, it's toast. And because they've still got their basement membranes, they can actually regrow the tubular cells, and it's got quite good regenerative capacity. So never say never, basically, if it's acute.
Do you have any like guidelines that you go on knowing how long it's been there?
And when you're trying to decide if you can do a sub.
No, I'm in this group called VIRIs, the Veterinary Interventional Radiology Interest something. And people send through cases all the time, and they send through pictures of ultrasounds of kidneys with ureteral stones, CTs and stuff like that. And the variation in presentation is so profound. And the recommendations you get from the group, who are all like nephrologists, essentially, they're really sort of subspecialized. Like one will say, put a sub in that, and the other will say, no, just leave it, medical management. It's really subjective and variable. Depends on the degree of obstruction. It's, yeah. And on the other kidneys function and stuff as well. On the cavalierness of the clinician. So no, short answer.
Wow.
So when we think about renal injuries, pre-renal, renal, and post-renal, and within that
Just
renal,
digress from this, what's the preference, sub or stent?
depends on the patient. I usually go stent for dogs and sub for cats. Cats are too small to get subs in, to get stents in reliably, and the stents tend to, because cats' ureters enter their bladder quite caudally, like really right in the neck of the bladder / urethra, the pigtails tend to cause a dysuria. So they're just not as well tolerated in cats. And I guess similar for small dogs. There's just not as much space in the bladder for those big kind of curly pigtails. All right, I'm not going to go through the iris stages because they're so readily available, and that's just something that you're going to look up when you've got a case and you need to sort of classify it. But essentially the difference between acute kidney injury and chronic kidney injury is that stage 1 or grade 1 is non-azotemic. It's just that classification that we've met that criteria, and we need to be on alert for progression and doing whatever we can to avoid progression of the kidney injury. And there's sort of phases of acute kidney injury where you get the initial insult, and then, like we talked about, all of those different compartments. If you get oliguria and fluid retention and overhydration, you can get swelling and things like that that can perpetuate the acute kidney injury. So that's called the extension phase. And then there's a maintenance phase where the healing sort of starts and you get some return to function. And then a recovery phase, which can be up to 3 months, depending on how many tubular cells they need to regrow and things. So you might not get stabilization of your creatinine. It might, so your GFR might improve over the course of 3 months after an acute kidney injury. So we sort of have them in hospital for a week and go, oh, there's no chance, but actually the regenerative capacity is quite good of the kidneys if we can support them through this. Having said that, it's 50% mortality in both cats, acute kidney injury, which I was surprised at. I would say that's quite high grade oliguric or anuric acute kidney injury, but it wasn't specified in the notes. So do we want to talk about, sort of talked about etiology a little bit, haven't we? Does anybody else, do we want to go any deeper into that? Nah.
The dehydration type of AKI is reversible. Like, do you get any permanent damage if you only dehydrated for like 12 hours? Do we think it's 100% reversible?
So there are so many nephrons. Theoretically, you're going to have lost a nephron.
Yeah, okay. Because I understand that, like a long time ago, I was told that even like spay and castrates, not put on fluids, like 3 weeks later, they have still a reduction in their GFR compared to pre-surgery.
Yeah, right.
So every single thing that we do might be damaging some nephrons, and you just get compounded injury just at the point where you reach a threshold where you have lost sufficient nephrons. So
exactly, yeah.
the kidney's got so much functional reserve. They're designed to lose the odd nephron when you get a gastro and get super dehydrated and stuff like that.
Wow.
But those, you know, for example, those dogs born with renal dysplasia who've got borderline renal function and then get gastro and they just tank, they just don't have the reserve to deal with that extra nephron loss. So as we get closer to an azotemia, we need to be more and more careful of every single nephron. So with anesthetics, medications, anything that, you know, you just can't afford to be careless with them, essentially.
Right. I never realized how that's the pre-renal causes were actually so significant.
Me neither. And every time I've read this, I've gone, that's right. Like, I really need to be less dismissive of them and more like, if you sort of, you know, if you get your bloods back the following day, it's not any help. But if you're doing, you know, bloods in a hospitalized patient, jump on a creatinine change, make sure that you're adjusting your fluids and being really proactive about managing that. Because it's really hard to judge outs, I find, particularly in gastro patients and stuff. Like, how do you quantify how much is sitting in the gastrointestinal tract, what's coming out either end? It's really difficult.
Way back in the dim dark past, when anaesthetics were not put on fluids routinely, it wasn't unknown that a week after a dentistry was done, particularly in an older animal, they'd come in renal failure.
I have to say, we see such a skewed population because we see all the disasters, but it's not uncommon to see acute renal failure post-GA with very careful, responsible use of non-steroidals and, you know, every precaution taken, even when they are on fluids. I feel like we had a staff patient, a surgery that was done with the utmost care at NVS, and every precaution taken, the staff patient developed AKI and creatinine of 800 or something. It was quite spectacular. And she made a full recovery in the space of sort of 10 days, but you can be the most responsible clinician and just be really unlucky.
And part of that dog's issue presumably was that maybe she was quite far along already, the reduction in GFR, but you didn't know, or maybe she wasn't, and maybe it's just other factors.
Because she was a staff pet, we did pre-GA bloods and her creatinine was absolutely perfect. She got non-steroidals subcutaneously once she was fully up and awake and documented comprehensive. Had been on fluids the whole way through the GA. But some patients are just more susceptible.
Wow.
The effects of non-steroidals. So she's not getting them anymore. Ever.
But this could only cause a problem if she's not doesn't have normal blood pressure.
In theory, but we documented she did. Yeah, it's pretty. I mean, I don't know how much fluctuation there is in blood pressure post-op, and whether maybe she was super sensitive to opioids and her blood pressure dropped when she got pain relief injection or something like that. Don't know, but yeah.
Wow.
I'm very non-judgmental of injuries that happen post-op, because if you gave no patients non-steroidals after their spay, you'd be compromising the quality of life of hundreds and hundreds of patients for that one that goes wrong. So I still think it's the right thing to do, because it's documented as the best form of pain relief in the post-operative period. But medicine people are very scared of them.
Yeah.
So the next part of my notes I've got is pathophysiology. It's obviously the part that I like. Is everybody happy to go into this? Yeah. Okay. We'll try and structure it in a logical way. So the two main mechanisms I want you to think about with how an acute kidney injury leads to nephron loss and therefore chronic kidney injury or chronic kidney damage, irreversible kidney damage, I should say. And one is intrarenal vasoconstriction.
so decreased perfusion of the kidneys. And the second is tubular obstruction. So can anybody think of things that could cause intrarenal vasoconstriction? We talked about some of them.
Do you kind of like classify the afferent and efferent as intrarenal, or is that you talking
Yeah, I would. Yeah.
so like non-steroidals and ACE inhibitors?
Yeah.
Would hypertension be one?
I don't think so. I think hypertension causes glomerular basement membrane damage, which causes proteinuria, or which then causes a tubulopathy and causes a tubular obstruction. So I'd probably put it into that category, I reckon. Yeah. So it shouldn't cause vasoconstriction. And we think about that vessel, we're not just talking about the glomerular vessels, we're talking about the vasa recta that goes around the tubule and provides perfusion to the rest of the kidney as well.
They could be obstructed with micro clots.
Yes, good. Yeah. So clots associated with systemic inflammatory disease. So intraluminal obstruction for sure. We talked about that floppy vessel going through a fluid-filled compartment. So if we talk about a luminal obstruction in the vessel, what about an extraluminal compression of the vessel?
Like an edema or like fluid overload?
Good. Yeah, exactly.
Is that the main cause of that increased interstitial pressure?
One of, yeah. Yeah.
Like inflammatory complex deposition being one as well? Or would that be more glomerulitis?
Inflammatory cell infiltrate, I would say. The two main mechanisms of swelling in the kidneys is inflammation and fluid overload.
Right.
So if we've got either of those, then we're going to get increased fluid within the interstitial space. But then in inflammatory diseases, so interstitial nephritis, for example, we're going to see an infiltrate of cells, which are going to then cause more inflammation and cause more swelling.
Wow.
What about a space occupying lesion like a tumor?
Good.
Compressive.
Excellent. So what is the most common tumor we see which causes a cellular infiltrate which would be significant enough to affect both kidneys and cause an azotemia? Lymphoma. Good. Exactly. Yeah. So they're the sort of main things I want to cover as far as the vascular causes or intrarenal vasoconstriction. Thinking about the mechanism of that vessel as far as it goes through the glomerulus and then it goes along the tubule and perfuses the interstitial space as well. If you've got dysfunction of that blood supply, what's going to happen to your tubule?
Become hypoxic, I think.
Good.
Get more injury.
Exactly. So vascular injury is going to cause a tubular injury. And what happens when a tubular epithelial cell, this is a hard question, sorry, especially because you weren't here a fortnight ago. What happens when a tubular cell loses its blood supply?
Probably it'll die in slough, probably.
Good. Yeah, exactly. And there's more detail between the reduction in blood supply and the dying.
Yes, it can't function, so you can't get exchange of or reabsorption or secretion happening.
Good. Excellent. Yep. So the main cell pump that's impacted by hypoperfusion, septic shock, all of those kind of acute inflammatory injury kind of mechanisms is the NAK ATPase pump. What's that pump's job? Is it bringing sodium in or out of the cell?
It's in, but it's probably not. I was just thinking because you often get hyperkalemia with you get both, I guess, but yeah, hyperkalemia. Yeah. So I was thinking sodium, the other way around.
Other way around. So its function in health in all the cells is in pretty much every single cell. Because you know how if you do a blood sodium level and a blood potassium level, sodium's really high, potassium's really low. And then inside the cell, it's the opposite.
Mm.
So the NAK ATPase pump's job is to maintain that imbalance, essentially. And that's why it needs ATP, because it's moving things against their concentration gradient. So that's, if that pump isn't working because we've got decreased ATP, because we don't have blood supply, so we're going to have decreased cellular energy, that pump stops working, sodium stays in the cell. What follows sodium?
Water.
Water. What happens to the cell?
It will be edematous and burst.
Yes, exactly. Yeah. So that's the most common kind of mechanism of cell death with energy changes in cell, and that can be metabolic or blood delivery, oxygen delivery, glucose delivery.
Wow.
So what happens once a tubule, so the tubule has just one blood supply and that blood supply gets damaged and all the tubular cells all at once lose their blood supply and they all swell and slough, where do they go?
Into the collecting duct and the urine.
Yep. And what do we see when we examine the urine?
Tubular casts.
Good. What do they look like? Are they hyaline casts or are they granular casts?
They're granular.
Good. Exactly. The cellular casts look granular. What are hyaline casts?
Shiny and smooth.
Pink.
There's no cells, but I don't understand why.
Very smooth. So what can you think about what else gets stuck and plugs up tubules in glomerular injuries in particular?
Protein.
Protein.
Oh, right.
What happens to casts when you send your urine off to the lab for examination?
They disintegrate.
Yeah, they disintegrate. Exactly. Particularly the granular ones. You need to look for casts in-house on a fresh sample. Do you do that all the time, Josh?
I think I've done it once.
You don't think you have, did you say? Or you have only?
I don't think I've done it once.
No.
As a new grad, I think I did it.
Yeah. Once.
Probably should do it more.
You should do it more. So that's one of the things that I would like to see done in every acute renal failure patient is a daily examination of casts, because that's telling you how many tubules you're losing. If you've got like wall-to-wall granular casts, you're in trouble. If you've got no casts and a polyuric patient, you're probably on the improve. Okay, so then the other thing that happens when we've got loss of tubular structure, so all of those cells are now damaged, they're falling off, there's gaps everywhere and stuff, is all of those mechanisms to control resorption of solutes and to keep the fluid in the tubule are lost. So we got loss of those tight junctions between cells, and we get movement of fluid from the tubule into the interstitium.
Right.
Which causes
edema,
which causes
decreased blood flow.
Yes, more vascular dysfunction, and it perpetuates itself. So tubular damage will cause interstitial damage, which will cause vascular damage. Vascular damage will cause tubular damage and interstitial damage. So they all mix in together, and all those nice classifications you had in your head go out the window. But that's sort of the kind of, I guess, story of perpetuation. So once we've got an obstructed blood vessel in the, say, in the medulla, what's happening at the level of the blood vessel in the glomerulus?
It's got backflow, so it's also high pressure.
Good, yeah. So we're increasing glomerular pressure and also getting glomerular damage.
Right.
And by increasing pressure, we get increased interstitial fluid in the glomerulus, decreased filtration, and decreased vascular function.
Right.
So let's just talk quickly about in what the phases of acute kidney injury. If you've got an auric patient, I want you to picture what's happening with those nephrons. What do you reckon?
So just like severe vascular compromise in that sense, like either from interstitial swelling or I guess we're not getting urine produced, so the nephrons are either compressed and not functioning or sloughing.
Yeah, exactly. So every single one of those nephrons is blocked. If you're auric. What about if you're
Or not like, is it always at the outflow end? Can it be at the inflow end?
Yeah, so that can be anywhere from the blood vessel leading to the glomerulus is blocked. So you could have like a renal artery obstruction, or you could have such severe interstitial edema that you've got vascular obstruction of the vasorector and the tubule, or you could have such severe tubular damage that all of the tubular cells fell off, like from a toxin, for example, and blocked all the tubules. And then you got your interstitial edema and stuff as a result of that. What are we talking about?
Polyuric patient.
Auric.
Oh, yeah, so anuria. And so if we've got every single tubule blocked with, and like such severe kidney injury to become oliguric or auric, right? That's so much loss of function. What about polyuria? What are those nephrons doing when there's polyuria? Why do we get polyuria?
Is it, I'm assuming, because that's later in the stage generally, isn't it? Like you get it like third stage or fourth stage?
You can have a stage 1 be either auric or polyuric, in theory.
So is it when, I guess there's two things I can think of. One would be going back to those pumps, like if they're dysfunctioning, then you would have increased excretion of sodium. So that would contribute to polyuria.
Yeah.
But if you've got no nephron function either, but you've got normal blood flow or returning blood flow, I guess that would cause it too.
No returning blood flow.
So as in so your kidneys are trying to return to normal function, so the insult's gone, and so presumably your blood flow is better, your edema is getting better, but you've got these sloughed nephrons that aren't being able to. So I guess all part of the same thing. So different solutes can't be exchanged.
Yeah. So a couple of different mechanisms of decrease. So you're exactly right. The mechanism is increased sodium moving through the tubule. So increased flow rate through that tubule. Two mechanisms of that is that we've lost 50% of our nephrons. So we have to filter 100% of our filtrate through half the nephrons. So those nephrons are going to be copying an increased filtration rate. So harder to resorb. The faster the fluid's moving through the nephron, the harder it is to absorb solutes from it. So we get a polyuria from that for that regard. And then if we've still got edema, we've essentially got medullary washout.
Oh.
So
they use edema and medullary washout?
You pardon?
Is it edema of the medulla and washout? Are they often simultaneous?
If you've got more fluid, it just dilates that because the medulla is so hypertonic. And if you put more fluid in there for whatever mechanism, whether it's polydipsia or edema, then you're going to get washout, and it's that sort of collecting duct function is going to be reduced. So then let's segue on to, now that we've got a really nice picture in our head of what's going on in there, into treatment. How do we treat acute kidney injury when they're azotemic and polyuric?
Well, fluids, obvious, I think. would be one, but you have to watch you don't overhydrate them.
Absolutely. Yes, very good. How do you clinically, how would you judge overhydration?
Like weight gain, and
Good.
if you can ideally place a urinary catheter and do ins and outs would be optimal, but that's not always an option.
It's not always an option, but it is the best option if you can swing it. It's going to be the best way to make sure that you're not over or under doing fluid replacement. Often when these patients arrive to you, they're dehydrated and polyuric. So I find it really hard to know what's our replacement volume, what's our maintenance volume. And because that kidney function is changing, our maintenance volume is actually going to change as well. So matching ins and outs and just having that replacement bag hanging, maintenance bag hanging. So maintenance is just the matching ins and outs. And then the replacement is making up the level of dehydration.
The other question I was going to say there is the choice of fluids to do that with. I mean, Hartmann's is a very high sodium fluid, and for maintenance, you don't need it that high.
Yes.
You only need about 45 millimoles a litre, I think it is, of sodium.
A bit more, but you're right, Hartmann's is a little bit too concentrated. I'm just going to let my dog in, sorry. He's just
That's about 134 millimoles per litre.
So we've got our fluid choices, 0.9% sodium chloride, 0.45% sodium chloride, Hartmann's and plasma light. So 0.9% is hypertonic, too much sodium or a lot of sodium in there, but also a lot of chloride, which is actually more important in this context, and we'll get there. Hartmann's it's fairly isotonic, a tiny little bit. The sodium level's pretty good for like relative to plasma. And plasma light is ever so slightly lower, I think.
Plus, I've forgotten, but I think plasma light and there's one other, they're more like about 45 millimoles of sodium per litre.
So what happens if you've got a polyuric patient and you give them a high sodium fluid? What happens to their GFR?
It increase it probably.
Yeah, absolutely. Yeah, got to get rid of all that salt. Now, the interesting thing that's sort of coming out of human medicine is that using high salt fluids, because traditionally I was actually taught 0.9% sodium chloride for acute renal failure patients. And that's actually associated with increased mortality in humans. And the reason's not actually the sodium, it's actually the chloride. So if you put more chloride in a patient, and often sodium chloride are kind of balanced in those fluids, and that moves through the tubules and is detected at the distal convoluted tubule, that actually is detected by the macula densa. Do you remember those cells? The tonicity. And that actually causes local renin release and vasoconstriction of the afferent arteriole. So you get decreased blood flow to the kidneys with high chloride fluids. And we're really trying to avoid decreasing blood flow to the kidneys in these patients.
Isn't it also that like sodium chloride is more acidotic compared to...
That's a really good point.
And
Yes.
renal injury already will have metabolic acidosis. So then you actually, I don't know how much, I mean, theoretically, like that's the point. Actually, clinically, I actually don't.
I think because the kidneys, like normally you can just put whatever fluid in and the kidneys are going to work it out, but the kidneys aren't working. So I think a neutral fluid is a better option. So when you look at the human studies, 0.9% sodium chloride was, when you gave 0.9% sodium chloride, the GFR reduced by 20% because of that blood flow change. It's quite significant. And when you gave low chloride fluid or isotonic, like the right balance of chloride, there was a significant increase in survival. So that's probably the biggest consideration in fluid selection. And I would base that on the patient's chloride level. So if they're hypochloremic, I'm probably going to go with Plasmolite, which has a balanced chloride level. And if they're normochloremic, I'd probably go with Hartmann's, which is just mildly restricted relative to Plasmolite. So the biggest factor is not actually the sodium in the fluids, it's the chloride, which is weird because we just sort of say chloride just follows sodium. And we talked a little bit about rate and how we're going to monitor hydration, because what happens if we overhydrate these patients? What happens if they go from polyuric to oliguric while we're watching them? How are we going to detect that and adjust our fluid accordingly?
The urine output is probably our best only way, or if their weight starts going up quickly.
What about blood tests? What could we see on blood tests that might be an indicator of hydration?
Creatinine's going up.
Urea.
Creatinine's tricky because we've got renal intrinsic creatinine elevations as well as pre-renal. So as a marker of dehydration,
Potassium going up as well. And
potassium will be a marker of oliguria developing for sure. Yeah. What about PCV, TPP?
It'll go up.
Oh, yeah.
like your osmolality will change, I guess, in that sense. So,
Yeah.
so would you get?
They'd go down in synchrony with each other.
The PCV and TPP?
Yes, totally,
Yeah.
yes.
So if you're monitoring weight, PCV, TPP, and urine output, and you all of a sudden you've got a slight reduction in urine output and you think, is this just like the catheter was kinked? I'm not sure. But you've also got a reduction in your PCV, TPP, then that fluid that didn't come out stayed in the dog. No, because you've got dilution of that PCV, TPP. So it's probably less variable than lights and creatinine in the context of a renal injury.
Right. And it's trickier than when you've also got a patient that's initially dehydrated too, right? Because you're going to want some reduction in
And
PCV.
weight gain as well. Yeah, absolutely. Yeah. So if I find that first 24 hours really tricky.
Right.
And
But yeah, okay. So after that 24 hours, it might
once
be
you've rehydrated,
more stable.
yeah, exactly. Yeah. And what about blood pressure? Is that a helpful marker of volume load?
Yeah,
It could go up, couldn't it?
Could go up. Yeah.
go down if they're volume depleted as well.
Yeah. It's not foolproof because they're often hypertensive because of the neurohormonal response to renal injury. But it is, if it's sort of been quite stable and all of a sudden it goes up, you might think, oh, okay. And particularly if it goes up at the same time as renal output goes, urine output goes down. Would you ever use mannitol in these patients if they were oliguric or anuric?
Yes, I believe. Yeah.
Yep.
I know the that's like to.
Yep. Why would you do that?
I think the idea there, similar to like dextrose as well, is you're trying to promote polyuria in a way, or trying to kickstart the need for solutes to be removed. So sodium to be removed or glucose to be removed.
Mm-hmm. So what is mannitol?
It's a hypertonic fluid.
Yeah, perfect. And how's it excreted? Yeah, through the kidneys. Who said that? Nobody's mouth moved. Natalie, hi. So it goes through the nephron. So it pulls fluid with it. So what we're trying to do with mannitol is to unplug those tubules, increase flow through them. So we've got all this pressure on the outside from the interstitial edema, and we're just going to increase the pressure on the inside and try and unplug them. And in doing so, improve GFR. that it's got some off-target effects of having sort of antioxidant effects and things like that, and it actually decreases renin, and therefore locally we get improved perfusion of the kidneys as well. So there's a few different reasons why it might be helpful. What about frusemide?
Yes, I think it's another, but I think I read this in studies on this, there's no difference in mortality with frusemide.
No.
But yeah, I think it's similar kind of concept. You're trying to increase.
Flow.
Yeah.
Yeah, exactly. Would you use it in a patient that was dehydrated? No.
No, you need to rehydrate them. Same with mannitol, ideally.
Yeah, exactly.
If you use them both together, you need a very large bucket and mop.
Urinary catheter. You just need to up the frequency of the bag changes.
So if either of them work, you can keep doing them, but if they don't work after one go, you stop. Is that correct?
Yes, that is correct for right then. But then if like something changed in the patient, then I try again.
Okay.
Like there's sometimes the urine output, like, you know, it was here and the patient was dehydrated, but then I rehydrated it and the urine output didn't go up and it should have gone up. So then I'm going to use some mannitol. So yeah. All right, we better wrap up. Next, I think we're chronic kidney injuries, chronic renal disease. So that should be fun. And I'll write you an exam question on this one, Josh, that you can answer in the meantime.
Cool. Sounds good.
Are we going to start with a nice segue between AKI and chronic kidney injury?
I don't know. Did I do a segue today?
No.
No.
I don't know how one goes to the other.
Oh, I see. Yes.
Yeah.
Well, that's what causes all chronic kidney disease is many acute kidney injuries. Yeah, there you go. There's your segue. All right. Nice to see you all.
Thank
Thanks,
you.
everyone. Have a good
Thanks,
day.
Anna.
Bye.
Thank you.